Are you a doctor feeling crushed by administrative work? What if you're leaving tens of thousands of dollars on the table without even realizing it? This episode, we're joined by medical billing expert Dawn Osland. She unpacks the chaos inside Alberta's 1,200-page billing manual and introduces her new AI agent, Betty, designed to help you get paid for the work you're already doing. Stay tuned.
We need to break the system. We need to simplify it. It shouldn't be in a book any more than 100 pages. I remember back in the day, I used to be able to bill for a whole entire clinic, and it took me probably 10% of the time that it takes me actually now to look after the same size clinic. Physicians tend to underbill, quite a significant decrease in their revenue. You're looking at about $95,000 loss a year.
How concerned about audits should an average physician be?
It's quite more common than people think.
Have you noticed any discrepancies between how the PCPCM model has been advertised to physicians versus the reality?
Yes and no.
What percent of them regret switching?
Maybe about 10%. When the first panel payments came out, there was a lot of doctors that were like, this is a lot lower than I thought it was supposed to be. Well, how are you doing your diagnostic coding?
All right, so finance seems to be the topic of the month here. And Dawn, you've been immersed in Alberta's primary care world for a couple decades now. From your perspective, how has the admin burden evolved from the simple cost of doing business into what many are calling a full-blown crisis?
Well, I've seen a lot of changes in our financial system over the last 20 years. And in the beginning, it was a lot simpler. Our schedule of medical benefits, didn't have all the additional layers to it that it does now. So I have seen that there's been quite an increase, like you say, chaos for the amount of admin work related to that work around, doing their health service code billing, their diagnostic code billing. It now takes a full team. I remember back in the day, I used to be able to bill for a whole entire clinic, and it took me probably 10% of the time that it takes me actually now to look after the same size clinic, because there's so much more intricate rules and regulations and governing rules that I found it's really turned it into more of a bigger team administrative sport than it used to be.
What was actually different? So they've been updating the rules or the codes, or how has that changed over the years to make it more complex? Because I was only born into the medical field a couple years back, and so I kind of just inherited it in its current form. What did it used to be like?
Well, you got to think a lot of different codes that have came into play over the last even 5-6 years, even since COVID. We didn't have virtual visit codes. We didn't have email codes. We didn't have these different codes which are great because they help with the cost of doing business that way. But there are additional layers that need to be learned, not only by the physician, but by also each of the clinic team members that, are helping out with that processing of that email to make sure the physician knows it did go out and they can bill for it. So there's all those additional layers, plus with the expansion of modifiers, which are great and we need them. But it also keeps adding layers and layers of complexity, especially when there's rules related around them. There's some billing codes that have some crazy rules, like for example, you're emailing for a patient, your 01 or 03.01S. It has these crazy rules around it. If you've seen the patient the same day or they were seen by another healthcare provider in your clinic the week prior, that you can't bill for it. So it's like having to have a secret decoder ring to figure out, well, can I actually bill for this? And so it's those layers of complexity I found have made it quite an administrative burden today compared to where it used to be.
Okay, so a bit of a double-edged sword, careful what you wish for. We got the fee codes, but it definitely has added more to that headache. And of course, just you can't go more than 10 minutes without hearing about, burnout and the administrative burden. And so all these little things just wind up adding more and more tasks to the to-do list at the end of the day.
Very much so.
When you're dealing with somebody who's new to Alberta, whether it's an international medical graduate or somebody who's moving from a different province, what are the biggest things that they're surprised by when they show up and get the full, here's the introduction to our system?
I have to say one of the biggest things and is the size of the scheduled medical benefits. The fact that it's 1,234 pages long and honestly reads like stereo instructions from the 80s.
Yeah.
That is a little overwhelming for them. And that tends to be like, oh, wow, I have to learn that too. And another hiccup that I've seen, especially with international medical graduates, is ICD-9 codes. They may not have utilized that level of diagnostic codes, where, for example, if they were in the UK, they might have used ICD-10 or they might have used a different form of diagnostic coding. So that is a bit of a hurdle as well, because that is a very intricate part that plays into your healthcare coding as well. So that is some of the biggest ones, is the amount of knowledge that they have to learn in order just to invoice for their patient visits, and it's a little overwhelming for them.
I didn't realize the whole schedule of benefits was that long. Holy smokes.
Yes, I actually have a printed off copy I keep right beside my desk, so I never lose touch with the size of that book.
That sounds like a good way to fall asleep if you're having a restless night.
Yes, it is. And it's a great paperweight, or it's the size of it is even good for keeping a door open.
What's the actual difference then, ICD-10 codes versus 9? Is it the same type of system? There's just different verbiage. It's almost like learning a new language, or is it actually like organized differently?
I haven't dug too deep into ICD-10s, but what I can tell you about ICD-10s here in Canada is in primary care, we tend to use across our family physician offices, that type of thing. We tend to use ICD-9 codes, but you will see ICD-10 codes in other provinces, specifically more in hospital use. That's where you tend to see a lot more of those codes being used, and in the US as well.
Gotcha. Okay, so a very similar system. It's just, so you get into medicine, and then you got to learn Latin so that you understand what's going on with the body and all the systems and diseases, and then you got to learn your ICD-9 codes, and then if you're new to the province, you might be having to learn a fourth system on top of that one.
Exactly. And then if you move to another province, you're learning a whole new system in that province again.
And the fun just keeps going.
Yes, it does.
And so I guess you could definitely see the fee-for-service model as a big driver of the admin burden problem. So in your view, from your perspective, what are the specific features of that fee-for-service system that have contributed the most to physician stress and to uncompensated work in the after hours?
I would say the number one thing would be the CMGP modifier, which was introduced in 2009 and has been working in its current format since about 2011, 2012. And because the CMGP modifier allows a physician to be able to bill for that pre and post appointment administrative work of reviewing the chart, the charting afterwards, the writing referral letters, is a lot of times that gets undercalculated when it comes to billing to Alberta Healthcare, especially considering those tasks have to take place on the day of the patient's visit. That really limits the availability to utilize those modifiers. And I have really seen that physicians tend to underbill for the amount of time and the complexity they're spending with those patients, especially when they're doing the after hours work. Because how many times do we think we sit at our computer and we spent an hour and then somebody next to us is telling us, no, you were actually on it for 2 or 3. So we as human beings tend to think we're a lot quicker at things than we actually are. And I do see that kind of flowing into that different modifier use within fee-for-service, and has had from what I've seen, quite a significant decrease in their revenue when they're not utilizing it properly.
All those chronological optimists wind up shooting themselves in the foot by underbilling.
Yes. And it's very easily done, very easily done. A good example is a 55-year-old female patient comes in for a follow-up visit. She's scheduled for 15 minutes. Well, the physician spends 22 minutes in the exam room with the patient, then spends another 10 minutes on the pre and post work, as well as an additional 10 minutes doing charting, billing, etc. Gets that all done on the same day. Now we're looking at 42 minutes of entire time spent pre, post, and during. A lot of times the physician will only bill 1 or 2 CMGP units for that, therefore leaving themselves at a loss from $38 to $58 for that patient visit. Now you do that times 10 patients a day, 5 days a week, you're looking at about $95,000 loss a year for work you're already doing and you're entitled to be paid for.
Are you a healthcare professional ready to take the next step in your career? Do you dream of a role where you truly make a difference in a community that's perfect for you and your family? Well then, let me introduce you to Cherry Health. Our platform puts thousands of healthcare opportunities right at your fingertips. Explore jobs by location, specialty, compensation, and more. All on an intuitive map-based platform, available on Android, iOS, or your computer's internet browser. Create your professional profile for free and get started messaging directly with employers. Beyond the app, Cherry Health also offers personalized, white-glove recruiting services who can guide you every step of the way. Your dream healthcare career is just a click or a phone call away. Visit www.cherry.health to start the next phase of your journey.
Holy smokes. And so is it the CMGP modifiers wind up being the biggest volume of cash left on the table when it comes to billing, or are there like other things that you flag often as being bigger problems than that?
I flag the CMGP modifier is one of the bigger ones, but there is a lot of different things that are getting missed as well. Could be simple things, for example, as you've seen that patient and you also gave them their B12 injection. I see a lot of injections being missed in visits, liquid nitrogen treatments. I see that being missed as well, as it's just those little add-ons, but they forget that you can layer those claims together and that some of these claims do pay together. So I do see that that is a miss, as well as some physicians, if you're doing, let's say, more than one procedure in a visit, a lot of physicians don't know that that secondary procedure usually will pay at 75%. You may not get the full 100%, but 75% is better than 0%. So that is one area I see a lot of revenue loss as well when they're doing multiple procedures but not actually billing for all of them at the same encounter.
Okay, very interesting. And then certainly you've been using the new PCPCM model that's been all the hype lately, or at least we've been hearing about it quite a bit in the physician sphere. Could you give us kind of the quick and dirty overview, the rundown of just how that works now for people who aren't familiar with it?
Well, the PCPCM, it's quite an interesting new model. It's basically, it takes your original Schedule of Medical Benefits, that lovely 1,200-page book, and we slap a 4-part algorithm on top of it. Now, to break it down nice and simple, it basically breaks down your payments into a portion for your encounter, a portion for your direct patient care time broken down by hours, your indirect patient care time broken down by hours, plus an additional payment for your panel complexity. Does it sound confusing? You bet it is. But overall, it applies for a physician, let's say, that does longitudinal care. A physician that's looking after a panel. You need to have a minimum of 500 patients to qualify for it. And preferably working in one location. If you're working in multiple locations, that can get really complicated and a bit headachesome. So if you have the qualified panel number and you're practicing that longitudinal care, if the physicians I have been working with, there's been a mixed group. Some of them have really enjoyed it. We've had a couple that have found it about similar to what they were billing before, but on the average, we have found that they have found it has been more easy to be able to track what they're doing. In the past, physicians, for example, with the CMGP modifier, it was per patient and done that day. I've had a lot of physicians tell me that now that they are able to track their time in the amount of hours they spend in a week actually doing that care, and it's not tied to a specific patient, it's given them, they said, more flexibility. They're not having to really track every single little movement with every single little patient and every piece of paper that's related to that patient's journey for that visit. So it's given them more freedom, I have found. However, I did ask a few of them, because when's the last time you had to track how many hours you're working? I bet you it's been high school, med school, where you've actually had to, have an hour clock. So I did ask a few of the physicians if they found that was a little bit different. And I did have one or two that said it took them a couple of weeks to get into the habit of kind of punching a time clock at home to make sure that they weren't missing those extra hours, but that a few of them said that their wives were really helpful at making sure they didn't forget.
Well, I could imagine.
Yes.
Well, it definitely, coming from the CMGP system, I think most doctors wind up setting up their schedules to just be in line with those 15-minute appointments, versus now it seems like it would be a lot less constraining that way. Instead of having to try and time things to match with those CMGP modifiers for your standard visit, you're kind of just okay, I'm just going to see my patients, and then all of the, let's say, the computer work, the forms, the stuff after, you can kind of get into a bit more of a rhythm and just do that all at once, versus that switching cost of trying to computer work back to the next room for, in-person care, computer work quickly, back to the next person. You'd probably get into a bit more of a flow that way now with the new system.
Yes, that is a lot of feedback. One of my physicians in particular, he has said to me he's never felt so efficient, that it has given him a real boost in efficiency on how he's structuring his day, and that he wishes that this would have been around a few years ago.
Okay, well, it's definitely some good feedback to have got initially here. Well, maybe there is hope for us.
I do think it is a good system. You know, anything has its intricate rules to test out, but overall, so far, I find it's been interesting, and I'm curious. It has brought to light a lot of information that we have been trying to teach clinics and physicians for years and related to billing. And I find now with this new model, it's brought things to the forefront within a month or two. A good example is diagnostic coding. When the first panel payments came out, there was a lot of doctors that were like, this is a lot lower than I thought it was supposed to be. So, and I worked with a couple of them and I said, well, how are you doing your diagnostic coding? And we pulled some reports and found that 20% of the time they were using a 780 instead of using the more appropriate diagnostic codes for whatever that visit might be for those patients. And they did find that some of those codes were associated with some of their more complex patients. So they were able to see within a first couple of months of being on the new pay model what an impact that diagnostic coding was actually having on defining the complexity of their patients. Where in the past, that's something we've tried to teach in the system for a long time, and it never really got that uptake. Where I find now that it's tied to something that we can show right away, we're getting more interest in wanting to be an active part in making sure that those are coded more properly for diagnostics. So that has been a really interesting feedback from it, which I found was, I think, an unintended consequence of the program, but I have found has been a major benefit for my clients.
Very interesting. Like, just drawing on my own experience there, and this is probably somewhat primitive from your perspective, but when I was taught in residency, it was, the only time the diagnostic code really mattered towards your billing was if you were putting in like a mental health billing code, and in which case it just had to start with a 300 something something. And beyond that, it just never really mattered. And so that probably on the back end in terms of statistics and just, the health data tracking probably resulted in a lot of like not great data coming in the first place.
Well, you got to think our HQCA reports that we get that tell you, your percentage of diabetic patients, that's based on diagnostic coding. Same with the CIHI grouper. They base all that on diagnostic coding. So a lot of our healthcare data all across coast to coast here in Canada and provincially is based on that diagnostic coding, but we don't teach the importance of it in medical school, in nursing school. We don't highlight it as much as we probably should have.
Interesting. I'm starting to think now that the shift to the PCPCM model is probably adding to that complexity and arguably that admin burden in the first place, because you still got to know you get your fractional payment for the fee for service stuff, so you still need to have your 1,300 page manual memorized, and then on top of it now you got to get a little more into the weeds when it comes to the diagnostic codes and the timing. You're making a really good case for why billing is probably a good idea.
Yes, I do find that billing support is good, and if I'm being completely honest, I think we're coming to that point in our healthcare billing system here in Alberta where we need to break the system. We need to simplify it. It shouldn't be in a book any more than 100 pages. 1,234 pages is outrageous. And we've innovated so much in our system over the last 20 years, but yet we're still using that same old crazy book. It's time we make it easier for all the physicians in the province.
Very cool. Well, it's good to see things getting updated, whether it's bit by bit or drastically. It's kind of funny that thinking about this, but when we first started with the whole Cherry Health business, this would have been like probably 5 years ago, we acquired a couple different mentors as part of the venture monitoring service program through the University of Alberta there. And one of the mentors that we acquired, he had been working on the original, like the back-end computer system for the physician billing for Alberta Health Services. And that was, I think, like in the 80s or 90s. And he said they were still using that same core technology. This would have been 2020, 2021 when we were talking with him. But it was kind of funny just to think about, like how archaic some of the software, some of the programs that are still powering the whole province are.
Yes, exactly. They are very outdated. Hopefully, with all these advances in technology over the next, few years, we see that change.
So tell me a little bit more in terms of the PCPCM model. Who is the ideal demographic for making the switch, or who's going to benefit the most from switching over?
Now, physicians that are practicing longitudinal care, that wants to dedicate their practice to looking after a panel of patients. That is who it's most suited for. Now, if you're a physician who only works 2-3 days a week and diversifies your time, let's say between long-term care and other aspects in the healthcare field, which a lot of physicians do, it may not be the most best program for you to go on. I do find that for your physicians that are working 5 days a week, that you are putting in that amount of time, that it really is a good opportunity for them to look at it. Now, with that being said, I have had some physicians that are full-time physicians that are such amazing billers that they have stayed on fee-for-service only for the sake of that their brains will work a little like a computer. They're a very small group, so their billing, they didn't see quite an increase when they did an assessment related to it. But for anybody practicing longitudinal care, especially if you're working 4 or 5 days a week and you're putting in long hours, and if you have a large panel, that is another thing as well. A bigger panel, I find that it gives you the availability to be able to look after them that little bit more without feeling like you're constrained to only the patients you've seen that day. So I do find that would be who I would recommend, is more your longitudinal family physicians.
Okay, so those doctors, like bread and butter, classic family medicine, that is sort of the ideal demographic.
Yes, for that ideal, traditional, old school type of family medicine, yes, that's what I would recommend who it's for.
And then there's the minimum threshold, like the 500 patient panel, just to qualify for that in the first place. Are you finding that for those doctors that are, let's say they're doing diversified, something different throughout their week, and maybe they're doing 3 days a week of family medicine, that classic clinic, maybe they've got 600-700 patients, or maybe they're just barely hitting that minimum cutoff. Is there like a threshold that you've found in doctors switching over where it still does wind up being beneficial? Or is it like, if you qualify, switch over, or the opposite, like some people qualify and it winds up actually being a negative to their billing unless they're, 1,000, 2,000 patients on their panel?
See, I've seen a little bit of mixed reviews. I've seen some physicians that only have a 500-600 person panel that are doing quite well on it, because they have small families at home, so they want to make sure they're getting into those 500 patients, 600 patients are getting in to see them quite regularly. What I have been recommending to a lot of physicians is to look at what the return visit rate is. How many times are your patients on average returning over the course of a year? Because that'll really help to see, how fast you can get them in. Now, the one drawback with this PCPCM is the bigger your panel, the bigger the panel payments. Now, that can be dangerous, because at the end of the day, even if a physician is working 5 days a week, even 10 hours a day, you can't look after 5,000 patients a year. It's not possible. It's, the supply and demand, it's just not there. So that's something, is to really take a look at where kind of your panel threshold is. How often are they coming back in to see you? What is your capability that you have available? For doctors who are looking to start out and are just kind of shooting at the 500 panel mark, I do recommend to them, and I have to some of my clients, to go to 600. Because you do have, if you fall below that 500, you have 12 weeks to get it back up before you might come off the program. So if you have 500 patients and 2 families move away, all of a sudden you're under the thresholds. So I do recommend to any physicians that want to transfer over, hit that 600 mark. Yes, you qualify at 500, but if you want to cap your panel at 500, maybe do it at 6 or at 550. So you have that bit of a buffer, so you're not worried if a couple of families move away or transfer that all of a sudden you have fallen under that threshold, because you only have 12 weeks to get back up over it before they would actually take you off the program.
Gotcha. Okay, that makes a lot of sense. What about patients who they cheat on you? Maybe it's your fault because you didn't have accessibility and they couldn't get in for their acute problem, or maybe it's not. They were just fickle and felt like going to a different clinic or walk-in. How is that actually handled in terms of the penalty when it comes to this is my patient on my panel?
That's a great question. Right now, for the first 12 months, from April 1st of this year until the end of March of next year, there'll be no penalty if a patient happens to show up on more than one doctor's panel. But, and this is the but, as of April 1st of 2026, that will not be the case. If a patient is showing up on Dr. X's panel and Dr. Y's panel, nobody gets the panel payments. And then those two physicians, we're setting up our clinic managers, our MOAs, and our doctors, unfortunately, to start fighting over patients. Well, this is my patient. No, this is my patient.
Okay.
It's going to be a mess. It's going to be a mess come April 1st. So it's really important that every clinic is looking at their kind of panel management systems now, instead of waiting until the end when it's starting to, so you're not having that back and forth. And we're already seeing it in some clinics already where it is happening, where clinic managers are fighting over patients. No, this patient's been coming to see us for 3 years. Well, no, they've been here for 5 years. And we all know there's a lot of patients. There's 750,000, 800,000 unattached in the province. There's a lot of patients to go around that need a family physician. But that is one of the biggest drawbacks that I do see with this PCPCM, is I do not think that we are going to be prepared for what's going to happen come April 2026, when all of a sudden panel payments are going to significantly start to drop for some physicians, and they're going to be put in a position where they're going to have to start taking a more active administrative role on figuring out why it's that way, and probably engaging with some of their colleagues about these patients. I do think it's going to be a bit of a headache for them come next spring.
Have you come across any guidelines or advice in terms of counting a patient towards your panel? Like, let's say the patient has come to the a walk-in clinic and you've seen them quite regularly throughout the year. Like, you're not their family doctor, but their patient's calling you their family doctor. I've had this happen numerous different occasions. You start getting CC'd on different results, or like, is there any kind of guideline as to how to handle that so there isn't any kind of infighting?
Well, in the province here, we've had a lot of different initiatives that we've passed over the last few years in regards to like panel management. The different PCNs and their quality coordinators have worked really hard with a lot of the different clinic teams to teach them about being able to have those conversations with the patients, as well about, identifying who their family doctor is. But it also goes a step further. A lot of it has to do with your internal workflow processes in your clinic as well. Do your staff understand when a brand new patient that, let's say, hasn't been there before is coming in, and you're creating their chart in the EMR? Do they understand what the word primary provider means, what an active patient means? Do they understand all those different mechanisms when they're putting in that chart? Because I am seeing a lot of workflows there where patients are, they came in to see a locum physician, it's listed as their primary provider, and then they're running into this, if it gets uploaded into CPAR and all of that, where they're running into all of a sudden, it's just from an administrative error, a patient's got put on another doctor's panel. So there is quite a bit of that. So being able to identify your workflows within your clinic, to be able to figure out how you're identifying your panels, how you are communicating with those other clinics as well as internally. I've also seen some crazy, I don't want to use the word infighting, but conflicts within a same clinic where there will be some doctors are on the PCPCM, some are on the fee-for-service, some come in and do some specialty days here and there, and then they also have a group of locum physicians that come in. There's been a lot of conflict between some physicians in regards to offloading. For example, if the doctor's on the PCPCM, the patients are supposed to be in to see them. But sometimes the clinic flow process has gone sideways, they'll put them in with the locum instead. Then all of a sudden, all these patients are getting booked in for a follow-up with not their family doctor, and this doctor on the PCPCM now is kind of violating this offloading rule without them even knowing that has actually happened in the clinic. So it really does come down to a team-based sport between your physicians, your clinic management, and your teams, making sure that your reception, medical office assistants are all kind of working on it together.
Okay, so there will be like a little bit of growing pains here for many of the clinics, but overall, step in the right direction.
Yes.
Attracting top healthcare talent is crucial for providing exceptional patient care, but connecting with the right professionals can be time-consuming and complex. Cherry Health bridges the gap. Our network allows you to showcase your organization, post jobs with precision and ease, and directly engage with healthcare providers actively searching for roles like yours. Whether you're an ambitious do-it-yourselfer or a seasoned recruiter, our intuitive web platform makes it easy to showcase your open roles and organize your applicants. Need a more personalized approach? Cherry Health Staffing Solutions offers dedicated recruiters to find and vet the perfect candidates for your specific needs. Build your dream team with Cherry Health. Visit www.cherry.health and start growing your team today.
Have you noticed any discrepancies between like how the PCPCM model has been advertised to physicians versus the reality of the implementation of it when it comes to a physician switching over? Like, have there been significant discrepancies or missed numbers that were put through the estimates for that initial calculator of should I switch over, or how many of my patients I think are going to qualify? Like, is the boots on the ground reality matching up with what physicians were expecting for the most part?
Yes and no. I find the boots on the ground reality is they didn't realize how much extra work would go into it. That has been one. How much extra maneuvering in your EMR would be needed, how much extra setup. I did find with a few of my clients, we did some what I would call day in the life real assessments. The AMA calculator for, the suggested calculator for looking at to see if it's a good program for you as a family physician, they didn't find as useful. They found it was an okay tool, but it gave you a possible in the future, this is what it would look like. Where a few of my clients were like, I want to look at the real hard data. So what we did is we took a week of their previous bills that already been paid through Alberta Healthcare patient encounters, and we transitioned it. We took off all the modifier amounts to it. We put everything back down to the GP base rate. We reduced it to the 68.5%. We removed anything that would have been out of basket or not qualified. And then we looked at that calculation of what it would have been for their fee for service. We did a rough estimate of how many hours they would have worked throughout that week, going by like what the standard research shows. And then the only thing we didn't put into it was the accumulation of the panel payments, because that, again, we didn't quite know where that would sit at until it's, the first one started coming out. And we found that gave a more of a kind of real life estimate that was a little more accurate to what they're actually seeing that they're getting now. Then where we found with using the AMA one, it did give us a little bit more of an overestimate that wasn't actually reflecting right back to what they were actually billing in their clinic that day. And some of the input lines, we weren't able to adjust them to kind of reflect the specifics of a certain doctor's practice. They were more generic, so we did more of that day in your life to get a real hard look at that, because they wanted to see the hard data of something that had already happened, not the idea of what could happen in the future.
How close did they match up? Like, was it reasonably accurate, or was it quite far off in some of those cases?
A few, I'd say anywhere from $2,000 to $5,000 in difference.
Okay,
so not a great deal. Not a great deal when you're doing an estimation, because even when we were doing the live data, it was an estimation. But they were about anywhere from like $2,000 to $5,000 off for the course of what they thought they'd make over the span of a year. So, but some of my docs are very much they like the hard, fast, real numbers. So.
God, so I thought you meant for that 1 week. I was like, holy smokes, that's quite a margin of error.
No.
Okay,
and then, of course,
so it was
all the
fairly close.
Yes. And then all the estimates that we did of a day in the life didn't include the panel payment, which was also kind of a bonus too, because a lot of the docs, when they looked at their assessment, were like, oh, I like that. And then it was nice to be able to say to them, yes, and then you get your panel payment too. So then they were like, oh, wow. So it was quite interesting that way for them.
Okay. And then of all the doctors, all the clinics that fit that sort of ideal persona, they're doing that, 100% full-time classical longitudinal care. What percent of them regret switching, who have switched?
From the ones I've spoken with, I'd say probably maybe about 10%.
Okay.
But a caveat with that, I find, is because they haven't fully fully dug into all aspects of it, or they might be in a situation where they're not having that clinical support that they need in order to make it, effectively put into place. There's so many factors that kind of play into that it's not just, the physician. It's about everything and everybody they have around them as well.
Okay, so there's still some hope that they'll be able to like make it work on the new model and benefit from it. It's still 1 in 10. That sounds like not a bad hit rate still. When it comes to the doctors who are having a mixed week, let's say is more commonly going to happen in rural care, where a majority of their week they're doing that longitudinal family practice in their clinic, but then they're also doing hospital rounds in the morning and then potentially some emergency shifts. Like, what are the pitfalls for a physician who's going to have to be using both systems, the PCPCM and the fee for service in a single day?
Well, one of the pitfalls in that situation, like you described, would be that they're going to have to be jumping back and forth between their two BA numbers, which could very easily get confused and billed under the wrong one, very easily. Under the PCPCM, any of your long-term care or any of your hospital stuff would have to fully be just done under your fee-for-service billing, whereas in your clinical would be under your PCPCM. I do have a couple of clients that actually do a little bit of hospital billings, and in the first month, that did happen. They actually switched them and were billing under the opposite. So it's the EMRs, I have to say, have gotten a lot better since the announcement of the PCPCM with letting us toggle back and forth between the two BAs, which I know a lot of the doctors have been happy about. And they are always making advancements to the PCPCM. So for example, in the beginning, you couldn't bill an out-of-province healthcare patient under the PCPCM. It had to be billed under your fee-for-service BA. Within the first couple of months, they corrected that, so that way you would still be able to. So that way, mid-clinic, you're not jumping in between BAs or schedules. Because could you imagine what a mess that would be, having two schedules? That would be just insane. So they are slowly starting to figure out ways to be able to bill it under your PCPCM and making the proper adjustments.
Okay, right on. That makes a lot of sense. Yeah, having to manage multiple all at once, that would be a tall order.
That would be a nightmare. Plus, could you think of a clinic admin? If all of a sudden now you're dealing with two BAs, two schedules for a doctor, and you've got 10 doctors in a clinic, that would be an administrative nightmare.
I guess then, do you have any other tips and tricks when it comes to the PCPCM model for doctors who, let's say they have already switched over and now they're trying to maximize their billing, optimize the numbers? What should they be looking at?
Well, when it comes to the PCPCM, is make sure that you are max packing your billing. So, for example, if you're doing multiple procedures at a visit, make sure you're putting them all on there. So that way you're layering each and every single one of your claims. For example, your patient came in for a physical, plus they also got liquid nitrogen done and their B12. Make sure all of those are on your bill. Some of them may pay at 75%, but still it's better to have them on. Another thing is making sure that you're tracking your time. That is so paramount. It's very easy for us to jump into our EMRs and know, okay, I was in clinic for 8.5 hours yesterday. But same with the CMGP modifier, which was indirect patient care. Tracking your indirect patient care nights and weekends at home is something that's paramount, because every hour is worth money now. So missing 25 minutes, missing half an hour, missing an hour, missing 2 hours, this adds up. So it's very important to make sure that you are not underselling yourself and that you are tracking all those minutes and hours that you're doing stuff. Even if it's a half an hour in the morning as you're drinking your coffee and you're checking your labs on the iPad, that is still billable time. So it's getting into that behavior of making sure that when you're doing those items, you're remembering, hey, I need to track for this because I get paid for this.
What is the qualification criteria for billable time? Is there any sort of things that don't count towards that?
Yes. A good example would be your driver's medical. That's a service that a patient's coming in and paying for. So that wouldn't be something that you would bill under the PCPCM. Plus, you would not bill your time for doing that as well. Another one would be your insurance forms. So any forms that are covered under your insured services, for example, that would be covered under Alberta Healthcare, yes, that time to complete those would be filled out. But all those dreaded insurance forms that you doctors get that are a third-party billing, the time to complete those would not be considered billable time under the PCPCM for your indirect care. So that
Okay,
is
gotcha.
one that's a bit of a drawback, I find. And, some of that paperwork, I hate to say it, does take quite a while.
And then when it comes to the time tracking, you've recently come up with the Track My Time app, I understand. How has the rollout there been going?
It's actually went really well. Now, with the Track My Time app, what it does is it gives the family physicians the ability to be able to track their direct or indirect time, be able to log it on the day that they do it, and it even goes as far as breaking it down into the number of units, because in order to bill for the time, you have to break it into 15-minute units. So if you worked 10 hours, it'll actually tell you how many units, so easy for transposing over. It also has an audit-ready feature in it, which I really love, because we all know that audits come, and with being a new system a year or two down the road, I guarantee those are probably going to start rolling out across the province. So I thought right away, how can we make sure that you have everything you need when it comes to tracking, especially that indirect patient care time that's maybe not in the EMR because you were reviewing articles, you were reviewing different things related to a specific treatment for a patient. So the Track My Time would give the physician the ability right on their phone in an app to be able to log their time for that night. Then it gives them a complete record of it that they are able to access right from the app or even share. Because we know that some clinics have billing agents or their MOAs help with it. They can share this non-patient identifying entry right specifically from their phone to a staff member who then can enter it for them in the EMR. And as an added bonus, because we want to make sure they're protected when it comes to audit readiness, is every month we send them out an audit readiness package, which gives them a complete spreadsheet, including their IP stamps of when their entries were listed, a complete copy of each of their entries, as well as a nice, beautiful graph that shows them how their time broke down. Because one of the caveats with the PCPCM is a physician is not allowed to break the 20% related to direct patient care that they give after hours in comparison to the regular business hours. So each month we give them a cumulative graph showing them where they're at. If they are getting close to that 20% threshold, that would activate a clawback from Alberta Health within the fiscal year.
Okay, cool. How concerned about audits should an average physician be? I can't imagine, I don't know, from your perspective, like how common have audits been done on your previous clients? Like it's not something that I've really heard much about other than the ones that make it into the newspaper for grotesquely overbilling.
It's quite more common than people think, believe it or not. Auditing, I find, happens quite often with different clients that I have, or I'm brought in to help with different clients that are coming under an audit. And it can happen for a lot of different reasons. So it's very important to make sure at the end of the day that you as an individual physician, because most physicians are professional corporation, that are working within a clinic. But at the end of the day, the buck stops with that doctor, not that clinic, not that billing agent, not that MOA. So when Alberta Health or Alberta Health and Wellness comes in to audit a billing thing, they're coming straight to the physician. So it is paramount that you're able to back up that last year, those 100 hours of direct time that you billed and you weren't in clinic that week, where did it go? Now, I can tell you from my experience, I have done some audits of clinics in the past, is auditors do not like if you hand them a box of Post-it notes or a booklet you've scribbled in, because you could have made that last week.
Yeah.
So having a digital record at the end of the day, we all know that's king when it comes to being able to show what's that you're ready for those audits. So with the Track My Time app, you get this package once a month. So if you're audited down the road, you simply just share these packages directly with them, and there's all your proof that you entered those entries at that date and time that you said you did.
Okay, right on. So making it a little more seamless, easier, foolproof. If you do get audited, you're not scrambling and trying to put out the fire.
Exactly, because nobody likes an audit.
Tell me more about how the CMGP calculator program can help anyone with missed revenue who's planning on staying with the fee-for-service system. What are you offering there?
Well, with the CMGP calculator, if you're still on the fee-for-service system, it is also available as an app as well on your phone or on your laptop or your computer right in your clinic, whichever you prefer. It is non-patient identifying. It gives the ability to enter in the amount of time you spent in the visit and all the extra little bits you did. And it gives you a total of CMGP units that you would qualify for billing to Alberta Healthcare. Now, our beta testing last fall that we did with physicians showed that they were on average leaving about 30% unbilled. codes. That unless it was a patient, if you've seen 20 patients that day, what sticks out in your head? Is that one patient that was you were a little bit longer with, the one that there was an excessive amount of paperwork? There's maybe those 2 or 3 that really stand out. But what about those other 10 that had all that extra work that you did too, but didn't really stand out in the day? Well, as you're completing your billing, you're under billing for that. So the CMGP calculator not only helps you to catch that, but also helps to, in a way, kind of retrain the way you're looking at your billing. So that way, when you are doing these things and you're completing the billing at the end of your day, you're looking back and remembering those tasks that you completed related to that patient visit that you can now incorporate in. And as an added bonus, our CMGP calculator and our Track My Time, they are completely free. So there's absolutely no fee for any physician to be able to use it across the province of Alberta. That's our gift to the primary care.
That's very generous of you. Thank you. How did you go about coming up with the program in the first place? Like, what kind of feedback were you hearing that this was necessary in the medical community? Like, I can't believe that people are missing up to 30% of their billable time. That's wild.
Actually, how I came up with it is one of the physicians in Fort McMurray that I worked with for over a decade. He trained me from the beginning. When you see a problem, you come to me with 3 solutions. And I kept going to him and saying, we needed extra staff. We need extra staff. And he kept saying, okay, how are we going to pay for that extra staff? And I kept finding the billing holes. And I had seen that he was underbilling with the CMGP modifier. So that's kind of where the idea kind of formulated from, was seeing these physicians and clinics over and over and over again underbill. But then when they needed resources that weren't able to be compensated for, by being able to prove to these physicians, well, if you do A, B, and C, we can get that staff member. That's kind of where the tools formatted out. It was being able to see, working with that physician in Fort McMurray, how he was missing things, and then realizing I wanted to be able to give this to every doctor in the province. So that's when 2 years ago I started sketching out the CMGP calculator on a piece of paper, and then finally birthed it into the tool it is today.
And is this like a freestanding standalone program, or do you need to integrate it with your EMR?
It is a freestanding program because we didn't want to wait. We all know privacy legislation is a lot. Getting patient identifying interactions with an EMR, exactly. I'd be looking at 3 to 5 years of red tape. I didn't want to wait 3 to 5 years to be able to help you today. So we made our tool non-patient identifying, and it is a companion app off the side, either on your phone or off the side of your computer. But we are looking in the future to have it integrated into the EMRs, because a lot of feedback we have received from physicians is they would like it right in their actual bill.
Very cool. And then what about when it comes to rejections and bills that have been denied? What's your suggestion for physicians managing that side of things?
Well, for physicians managing that side of things, I'm really happy to announce that we actually have a new healthcare billing intelligence coming out calling Betty. She's going to be launching in August, and she specifically helps family physicians deal with their rejection codes. You simply ask her what a rejection code means, and she will tell you what the code means, and she'll even tell you how to fix it.
So Betty knows all 1,300 pages of the schedule of medical benefits very, very well, I'm guessing.
Pretty well, yes.
Very cool. And so how do you actually interface with that? It's like a AI, like if you talk to ChatGPT in a Internet Explorer tab on your browser, same thing. It's just now we've cloned Dawn's brain and then integrated it at the same level there.
Yes, she's going to be available on you'll be able to think of Surrey for healthcare. Right on your phone, you'll be able to talk to her, so you won't even need to, you can have it on your computer or your iPad, but or even your Apple Watch, where you could simply ask her a simple question on your Apple Watch if you wanted to know what the diagnostic code was or what one of the rejection codes was, because she will also be able to answer questions in relation to all the ICD-9 diagnostic codes in common language. Now, when I say common language, when I first started out doing medical billing, I didn't have a very big medical terminology database. Now, ICD-9, our diagnostic codes, that's the way they're set up. If you don't have a medical background, it's difficult to find the right code. Well, Betty is so simplified that if you say cut on foot instead of laceration, she's going to tell you exactly what you're looking for. So you're able to talk to her even as if it was a grade 5 person asking a question or a very highly educated physician, which is really important when it comes to team-based care, because we all have different ways that we address things, or for example, even international medical graduates. What we call an exam room here in Canada, in the United Kingdom, they call a theater. So even those changes of how we call different things. So we wanted Betty to be able to be accessible for everybody, no matter what your education level was related to your healthcare knowledge.
Very cool. Are there any privacy security implications with using such a tool, or is everything sort of conducted on that? There's no identifying patient information in their level, so you don't have to worry about it too much.
Betty is non-patient identifying, and we do recommend to our users when we're onboarding them that, and remind them that you're not to be speaking to her in a way where you're saying, Janet Smith was in for her injection this afternoon, with her husband Roy. We don't want them speaking in that way. We would rather them speak in more generic tones in relation to using her, at least at this point. In the future, that may change, but for right now, she is to be non-patient identifying, and you would talk to her more in a generic way. You would talk to another colleague without saying a patient's name.
Okay, very cool, very cool. It's interesting to see like the back end of AI tools happening, because so far I've just been privy to a lot of different solutions on the front side, namely the AI scribes really just blasting off into the medical sphere. So it's kind of cool to see that the actual like administrative end is getting a technological upgrade here too.
Yes, it's very important because healthcare is a team-based event, and we have put out a lot of different AI tools and a lot of different opportunities for physicians, for the nurse practitioners, for the RNs, the LPNs, but we tend to forget about the admin in the back, the hubs of the clinic that actually keep everything rolling, and we really need to start bringing them the tools to make them more efficient, especially tools because AI, everybody fears that it's going to take my job. So I know at Osland Medical Billing Tools, one of our main goals is to make tools that work with you, not for you, and don't ever take your job over for you. It's meant to be a partnership of AI and the integration of the workflow at the same time.
Where do you foresee that partnership going for its future direction as things continue to develop and it becomes more sophisticated?
Do you know where I honestly see it going? Is right now we have a lot of what I call one-sided communication tools. And we want to integrate all these AI components into our healthcare teams. But what's a team member? A team member is not somebody that just listens to you, but somebody you can talk to and you can interact with. So I do see these tools formatting into their own, I don't want to say personalities, but their own type of workflow person and teammate, because it'd be easier to integrate all of them as a team member and less fear if it's a team member coming to help me do my job opposed to a team member coming to take over my job. So I kind of see that evolution of that kind of AI persona. Let's say, Jarvis for healthcare, let's say.
Well, I look forward to seeing it play out over the years. Definitely an exciting time to be in the medical space.
Yes, it is.
I guess any final advice, any last tips you'd give to the physicians, the clinic managers out there about how to better their practices?
Take a look at everything that you're doing in relation to clinic workflows. Number one is always make sure that your clinic workflows are aligning with the support that you're giving your physicians in relation to healthcare billing. And judge where your physicians are at. Meet them where they're at. Judge where their level is at with their Alberta healthcare billing, and help them to increase that knowledge by helping them learn how to do little bits at a time a little bit better. Because then as the clinic grows and as the team grows, you're able to work together for it, because billing really is a team sport. It isn't a solo thing that is done just by the physician anymore. So it's really about being able to listen to each other and hearing what that doctor needs. That is so important, and learning what their little hiccups are when it comes to billing, and then being there to kind of help them before they realize they need that.
And then I guess if anybody's realized they've got more hiccups than they want to deal with themselves, how can they get a hold of you? What's the best place to find you?
Well, they can reach out by phone, or they can reach out directly by email to dawn@cmgpcalculator.ca, and I will get directly back to them.
Awesome. Well, Dawn, thank you so much for sharing some of your insights and wisdom with us today. I really appreciate you taking the time. It's been fun.
Well, thank you very much for having me. It's been a joy to be here.